Hello viewers, this is Dr. Sam signing in today's Doctor's Voice. Viewers, today we are blessed to get two distinguished specialists. On my right side, I have Dr. Nicholas Kohn. He is a senior consultant neurosurgeon, Mount Elizabeth Hospital, and his special interest is neuro-oncology, minimally invasive neurosurgery, and functional neurosurgery. And on my left side, we have Dr. Kozo Pipin. He is a senior consultant cardiologist and electrophysiologist working at the Mount Elizabeth Hospital. His area of special interest is palpitations and atrial fibrillations, pacemaker insertions, all this area. So we will be trying to get to know all the details about cardiology and neurosurgery from these two distinguished personals. Stay with us. So I'll be starting with Dr. Nicholas Kohn. Welcome to Bangladesh, Nicholas.
Thank you.
Okay, so as I got to know, your area of special interest is neuro-oncology. So oncology or cancer fears us when it is particularly involved in the brain, that is or some condition for the common people. So what are the common types of cancer you found from this part of the world?
So I think it's still the most common type of cancer that we see. The primary cancer, meaning the arising directly from the cells of the brain, is a glioblastoma.
Okay.
Yes.
So how frequently you get cancers originating from other organs than metastasizing into the brain?
So metastatic cancers are also common, and these are usually from lung, breast, renal, colorectal sources. So we also see them arising. Frequently for these cancers, the primary source is known in advance. So meaning that people already know it's from the lung, but that with time, a certain percentage of patients will fail their regular treatment and then develop a secondary spread into the brain.
Into the brain. So about the primary brain cancer, you were saying that glioblastoma
Yes.
is a common condition.
Yes.
We know brain has different sort of manifestations of this, of the disease process involving the region. Which region is involved? For our common viewers, can you please give us an idea about the common symptoms of brain tumor?
I think still the most common symptom that people do present with tends to be a headache. That'll be a common manifestation. Over time, we will present with seizures, especially if it's close to those parts of the brain that are involved in movement. So we may get seizures. Secondary to that, patients may also have weakness, balance problem. Occasionally, if involves the visual pathways, they may have visual disturbances.
I see. So the most common symptom is headache. Apart from that, how do you offer treatment, particularly surgical treatment options for brain tumor patients and other neurosurgical patients? For tummy issues, we nowadays, in many parts of the world, keyhole surgery or minimally invasive procedures are preferred nowadays. For brain issues, what is the advancement? Do you still go for open procedures or minimally invasive process can be considered?
I think for more and more, for many of those brain tumors, minimally invasive procedures can be considered. Minimally invasive procedures, similar to what you mentioned earlier about the bowel, minimally invasive procedures for the brain offers faster recovery, less pain. Patients go home faster with less neurological deficits. Those tumors that are ideally suitable for minimally invasive ones are those that are deep-seated, found deep into the brain, or those that are close to critical pathways. So these are the two types of tumors that are ideally suited for minimally invasive approaches.
Okay. So when possible, you always try to go for minimally invasive procedures when it is possible for the patient. So what are the other indications of minimally invasive neurosurgical procedures? Can you please shed some light on?
Sure. I think the other thing that we frequently see a lot more, especially in Asian countries compared to Western countries, is that more patients in Asian countries have intracranial hemorrhage as a cause of stroke.
Yeah.
In Western countries, it tends to be more ischemic blockage of vessel causing the stroke. Asia, it's bleeding as a cause. And minimally invasive clot removal is extremely efficacious. It can really help, if done at the right time, improve outcome way more significantly compared to like classic open surgery. So doing an early minimally access blood clot removal improves outcome a lot more.
Okay. So apart from the stroke and brain tumor issues, can neurosurgical procedures to be extended for headache patients? Like, some different kinds of headache can happen, like trigeminal neuralgia and such kind of headache. Can it be considered on the most advanced cases?
In fact, microvascular decompression, which is the neurosurgical procedure for trigeminal neuralgia, is extremely efficacious. So meaning that if patients have, so trigeminal neuralgia, for the audience, is essentially a painful facial pain, and it's considered one of the most painful pain ever. Correct. It's essentially, in some places we call it the suicide disease, because the pain is so severe it drives people to suicide. Affects half the face in one of the branches of the trigeminal nerve, and that pain is extremely severe. Medication works initially and then quickly loses efficacy after a few months to a few years. And for those patients, surgery is really helpful. And I would recommend for those patients to be assessed by a specialist who does this procedure a lot, and maybe consider that operation.
It can give some comfort for those severely suffering patients of trigeminal neuralgia.
They are cured.
Yeah. So one more thing I would like to know, for Parkinson's disease, the shaking disease, which is not uncommon, particularly on the elderly group.
Yes.
With the drug, same like trigeminal neuralgia, you were saying that with drugs on the initial part of the initial course of the disease, patient sometimes gets better, but as the disease process going on, the drugs loses its efficacy. On those patients, can surgery be helpful?
Yeah, absolutely. So I think, as you mentioned earlier, and correctly, initially medical treatment works well. And in fact, this is in the initial stages when patients have Parkinson's, they start on treatment. It's named as the honeymoon period, because the medication works so well, and we take a tablet once a day, twice a day, or even 3 times a day, and the patient can function perfectly well. What happens is that after a period of time, usually 4 or 5 years, we find that we are on higher and higher dosage. The medication no longer works as well, or we have to take it a lot more frequently. And for this kind of situation happen, then I think we should consider a surgical procedure called deep brain stimulation.
So can you please shed some light on deep brain stimulation? What is it?
Well, deep brain stimulation, in the simplest term, is essentially a pacemaker. But rather than a pacemaker for the heart, it's a pacemaker for the brain. And what we do is insert 2 very thin 1 millimeter wire into a specific part of the brain. Okay, and the brain is a network. And in Parkinson's disease, that network is not functioning well. And if you can stimulate at the right location, very small location, 5 millimeters within the brain, it actually reverses a lot of the symptoms of Parkinson's disease.
Okay. So when is the right time for deep brain stimulation to offer in a patient of Parkinson's disease? It is on the, do you offer it on the last stage of the disease, or when is the right time?
No, I think there need to be a change in mindset that this kind of procedure should not be a last resort.
Yeah.
And that's better to do early. Okay, and by early, on average, we mean 4 years and above from the diagnosis. And essentially, by the time 4 years on, we know that if patients were to continue on the medication, we are going to have loss or decrease in their quality of life. And having the surgery early with medication combined with surgery gives them even better quality of life. People can keep their job, they can keep their family relationship intact, for many, many reasons.
So for Parkinson's disease, we must need to consider deep brain stimulation, not at the last option, but maybe after 4 to 5 years of the disease process, we can consider about deep brain stimulation.
About it, yes.
So is it a risky procedure, or very invasive, or very risky?
No, the procedure is considered generally very safe. Like I mentioned earlier, it's really about inserting 2 very thin wires into the brain, and everything else is just under the skin. Similar to a cardiac pacemaker.
I see.
It's all under the skin.
So it is, in a simplest term, we can label it as a pacemaker for the brain.
Yes.
So thank you, Dr. Nicholas. We got to know about some advanced issues on neurosurgical field. Thank you for your time.
Thank you very much.
Viewers, on this episode, we'll be trying to know about some neurosurgical issues and cardiac issues. On the first part, we were discussing about neurosurgical issues and recent advancement in the neurosurgical field and the options they are offering in Mount Elizabeth Hospital, Singapore. After the break, we'll be trying to know about cardiological advancements from Dr. Pepin. Till then, stay with us. Viewers, welcome back to Doctor's Voice. As we said earlier, we have two distinguished guests. On my left side, I have the heart specialist cardiologist, Dr. Kozadzizo Pepin. We'll be trying to know about heart rhythm disorders from Dr. Pepin. So, Dr. Pepin, welcome to our show.
Thank you. Thank you for having me.
What gives us heart racing? On a stressful situation, we tend to get some heart racing. But you, cardiologists like you, often say it needs to be addressed. When it is the time to visit a cardiologist?
Sure. So of course we expect our heart to race when we get excited, we get happy, we get scared. That's quite common, and commonly when people are stressed, you can feel the heart racing. But if your heart is racing for no good reason, and it races for a sustained period of time, and it doesn't seem to slow down even though you're relaxed and rested, then there's probably a suggestion that you may be having some heart rhythm problems. And that's when you should probably talk to your doctor about this.
Okay, so often when there is no appropriate trigger, but the heart racing continues to be persistent for a long period of time. So along with this, some of the time, often we see or when we encounter patients like along with heart racing, they tend to get dizzy or
that's right.
They find it difficult to stand. Do you think at that point they must need to visit a cardiologist?
Yes. So if you have heart racing and it's associated with other symptoms that makes you want to black out, you feel chest pain or you get breathless, then it makes it even more serious, and that's when you really should consider seeing a cardiologist. So
can you please give some idea about the common causes of palpitation or heart racing?
Sure. So for younger patients, it's often due to something called a SVT or supraventricular tachycardia. But for older patients, the most common arrhythmia we get is something called atrial fibrillation or AF. And that's really the most common arrhythmia that we see, not just in Bangladesh, but around the world.
Globally, that is most common. So about supraventricular tachycardia, what are the options of treatment you can offer?
Sure. So most of the patients with supraventricular tachycardias are actually either older children or teenagers. And so for a lot of them, there are two options. One option is that they can take medication, but most of the younger patients are not willing to take lifelong medication. So very commonly, they will come and have a minimally invasive procedure. It's called ablation. You just have to do it once, and it will get rid of the electrical wiring that's causing the supraventricular tachycardia. And after that, they're cured. So they don't need to take any medication anymore, and they won't have their palpitations again.
Okay. You were saying about abnormal electrical circuit must need to be corrected, and it's a one-shot treatment, ablation. So how often you go for ablation, and is the process absolutely same, safe?
So how often? So I think most people in their lifetime will only have ablation once. It's minimally invasive, so really I do this without a scalpel or a knife. We insert very, very small wires into the veins of the body, and through the veins, through the natural circulating system, we get into the heart. We know that most kinds of heart rhythm problems or arrhythmias occur due to abnormal flow of electricity in the heart. So we need to understand why it's flowing abnormally, and then you will use the ablation to correct the flow of electricity. Now, sometimes it's because the patients have an extra wire, sometimes it's because they have abnormal signals coming from different areas of the heart. Nonetheless, all the wires will help us to determine that, and then you take the correct treatment, and that will correct the electrical flow and solve the problem.
How do you identify whether there is some, what is the exact reason, or where is the troubleshooting? How do you identify?
Okay, so you can get most of the diagnosis actually with a simple ECG. So this is where you just put 10 dots on the skin, and you can have a pink color piece of paper. That will get you the diagnosis 90% of the time. at the time of the electrical study or the electrophysiological study, what we do is just to confirm what we understand. We know the diagnosis, we confirm the diagnosis. Then based on that, we are able to identify what is the best treatment for it.
I see. So for supraventricular tachycardia, which is the leading cause for palpitation in the teenager group, and can be done on a single shot treatment with catheter ablation. So for the elder group, you are saying that if atrial fibrillation is a common condition. So what about the reason behind the atrial fibrillation, and how do you offer treatment for atrial fibrillation?
So atrial fibrillation, because it's an older disease, there are lots of causes for it. The most common cause actually is age. So the older we are, the more likely we are to get atrial fibrillation. So by the time we are 80 years old, 1 in 10 80-year-olds will have AF. So it's actually very common. The other common things are things that we are seeing more and more frequently in society: high blood pressure, diabetes, being overweight, not exercising enough, sleep apnea, which is a snoring disease that you have while you are sleeping. Those are all common causes of atrial fibrillation.
Okay. What are the treatment options for atrial fibrillations you can offer?
So I think in Asia, where patients are typically more conservative, most patients will try medication first to control the palpitations. Unfortunately, the medications only work in about 30% of patients. So most patients, despite taking medication, they still have the palpitations. And even those whose palpitations are controlled initially with medication, after maybe about 2 or 3 years, the medicine will lose its effect. So you either have to switch medication or to consider other options such as ablation.
Okay. So another particular condition I would like to know from you, that is sick sinus. You know, on some elderly group of patients, we often find heart rate at some point it gets above 100, at some point it gets below 50. How do you explain about this condition, and what about the treatment options?
So the fast heartbeat component of sick sinus is basically due to atrial fibrillation. So that's what makes the heart race. At the same time, we are all born with a natural battery in the heart. And so this battery normally maintains our heartbeat at around 60 to 80 beats a minute. But for this elderly population, the battery is wearing out. So the battery is not working very well. And so when they are not in atrial fibrillation, their natural heartbeat is very slow, in the 30s and 40s. So there's another word to call this condition. It's called tachybrady, where they're either slow or fast, right? And they can't stay in the middle. And for the slow component, the only treatment for it is to have a pacemaker, and that's to make the heartbeat go back to normal.
Okay, so pacemaker can give a better quality of life for this patient. So how do you insert pacemaker? Can you just give us an idea?
Yeah, sure. So it's not just for the quality of life, but most importantly is to stop them from falling. Because often when the heart rate is very low, they actually black out and they can actually sustain quite serious injuries. The traditional pacemaker is basically a small battery that's about the size of a men's watch, and is inserted under the skin. It's done under local anesthetic. And there are 2 tiny little wires that goes through the veins into the heart. It's connected to this battery, and it will give you a longevity of about 13 to 15 years. So that's the traditional pacemaker. We now also have pacemakers that can be inserted without a cut. So these are small little pacemakers that look like a little bullet, and they are inserted from the leg. So it goes up the leg, and we directly put it into the heart. So these pacemakers have no wires. So they're called leadless pacemakers. They last for about 10 to 11 years. But the benefit of this is that there's no cut. The patient doesn't need to recover. And they work as well as the traditional pacemakers.
Okay. So now I'd like to know something more about acute emergency. You know, right after this COVID era, we have lost many of our patients with pulmonary embolism. So what is it for our viewers, and what are the advanced treatment options for pulmonary embolism you offer in your center?
Yeah, sure. So pulmonary embolism is when a blood clot forms, usually in our legs. And you know, in the veins of the legs, the blood has to flow back to the heart and then through into the lungs to pick up oxygen. Now, when the blood flows back, it carries this clot back, and the clot basically blocks the flow of blood through the lungs. So your blood cannot get into the lungs, you cannot pick up oxygen, so you get breathless, your blood pressure flops, you get very dizzy. Now, traditionally, people have treated this with giving blood thinners, but it would take almost 3 months for the blood clot to dissolve. So what we have developed is a very quick process whereby we are able to insert a very a long straw essentially into the lungs, and we are able to suck the clot out, and that restores the blood flow and normalizes the oxygen level. Now, COVID is a disease which unfortunately causes the blood to be much stickier, and so COVID patients are more likely to develop pulmonary embolism. And indeed, over the last 2 to 3 years, we've seen more patients like this, either associated with the COVID infection or possibly even sometimes after the vaccination.
Yeah. So with a straw, you can pull up the clot there on the lungs. So thank you, Dr. Pippin. We are at the end of our show. Lastly, do you have any message for our viewers, in a nutshell, to deliver?
I think for all heart and lung diseases, the key is to actually have a healthy lifestyle. So healthy lifestyle, exercise, don't be overweight, don't smoke, and all those things helps to prevent future cardiac diseases.
Many thanks for your time. I wish you have a safe journey back to your home. Thank you, Dr. Nicholas and Dr. Pippin.
Thank you.
Thank you.
So viewers, today we are discussing about heart and brain related issues and recent advancement on the treatment options for heart and brain issues. On the next episode, we will be discussing something else. Till then, stay fine, stay tuned.